Andy. Hey,
Yes.
it's Isa. If you can share your screen.
Oh my goodness.
Thank you.
Okay. Do you see my housekeeping PowerPoint now?
Yep.
Yes. Okay, great. I'm glad we're on the same page now. Okay. So we'll just start with some introductions. Shannon, if you could just begin, that would be great.
Yeah, so Shannon Nugent from the Richmond Hospital Vascular Access team.
And then David isn't here, so just Jordana.
Hi, I'm Jordana. I'm the manager for the Vascular Access team.
Perfect. Thank you. Okay, and then from our team, we have quite a few of us, so I'll begin. My name is Candy. I'm part of the generalist team, and my portfolio is the vascular access team.
Hi, I'm Isa Robidilio. I am also part of the generalist team supporting the vascular access portfolio.
Hi everyone, my name is Tiffany. I'm a clinical informatics specialist on the same team as Isa and Candy in the generalist team.
I don't think Hilda's here yet. Is Gabby here? No?
I guess it's you, Haley.
Okay, that's why I was speaking up. I'm like, maybe it's me now. Hi, I'm Haley Montgomery. I am the clinical informatics manager with the oncology portfolio, so basically cancer care.
Hi everyone, I'm Shan Lee. I'm from the CST acute care team supporting for meeting minutes today. Thank you.
Go ahead, Sonia.
Yeah, thank you, Haley. I work alongside with Haley on the clinical informatics team supporting RHS Cancer Care Clinic. Thank you.
Hi everyone, I'm Heather Eli. I'm from the CST scheduling team and I'm supporting the Richmond IV Clinic scheduling build.
Okay, and I think Gabby's
Can I just ask a quick question, Candy?
Yes.
There's a lot of people from the oncology team, but no representation from the oncology team itself. Is that needed today?
No.
Okay, thank you.
Andy, do you mind if I put a plug in there from the?
Yep, for sure.
I don't know if so it's a good point, Jordana. The scheduling of this is being handled with the kind of cancer care scheduling. So kind of what you're seeing is what they've already seen from a scheduling standpoint. But at any point, if you feel like during the meeting that you feel like maybe from a nursing's perspective, or if you'd like us to just kind of reach out to them and get their blessing also, then you can call that out and that's something we'll do.
Great, thanks so much.
Thanks.
Okay, so I'll just move along here. So the purpose of our session today is to review and validate the future state workflows and content in CST Cerner, specifically for the BAT team. So our guiding principles for change, guiding principle number 1, no change for the sake of change, and then guiding principle number 2. So our focus is on enterprise design. So we're configuring for enterprise-wide, so all 3 health organization. And so we're going to prioritize topics based on what's needed first in order to go live at Richmond Hospital. And then guiding principle number 3, our priority is must-have. So we will have many opportunities in the future to just fine-tune the system once we have everyone using the system. So the role of a subject matter expert to contribute and represent your area to review the design and workflow recommendations, to work collaboratively with the CST teams to finalize content and our workflows, act as an agent of change and communicate design decisions, and be an advocate for transformation. So Shannon, I know it's been a while since we've touched base, but previously in our sessions, we validated the inpatient workflows. So this here it just captures what we previously talked about. So we previously validated in terms of the inpatient workflow and using the PICC insertion power plan, the provider would enter the PICC insertion power plan in CST Cerner. That would receive this task via MPTL. They would manage their workload via MPTL and their site documentation, which was identified as being a whiteboard. That would review the patient's chart, determine if they qualify, and then prioritize using their whiteboard. And then there would be out-of-system communication to the unit regarding the PICC insertion date and time. And on the day of that would assess the patient, perform the intervention, and then in terms of charting, that would insert the ECG strip on the CVC tip confirmation form. They document the PICC insertion in iView and document an insertion procedure note, and then they would chart done on the MPTL. So that's just that was just a refresher of what we've discussed previously. And this was
Sorry, can I go back to that?
Yeah.
Who's the provider? Is that the physician, or are you talking about the?
Yes, a physician. Yeah.
So they input it.
Yes.
And so I know we had a lot of back and forth about involving a unit clerk. Where do they play into this workflow?
Yeah, so the unit clerk would be the out-of-system communication. So if Shannon and David needed to figure out the best time for the patient, they could communicate with the unit clerk. And it was brought to our attention before that this could be call, this could be in person. So depending on what, so either of those options would work going forward, because this doesn't need to be scheduled into CST Cerner.
Okay, thank you.
Yeah, no worries. Okay, and so this was the this was the PICC insertion power plan that we had looked at before. And so I'd just like to bring your attention specifically to the alteplase order, as there are some changes that are that will be made. And so the insertion power plan will actually look different. So this will be changing. And so what that'll look like, I'll just skip over to the next slide. So essentially the workflow will be quite similar to what we validated previously. However, the power plan will be a multi-phase power plan. So what this would mean is that on the day of, the vascular access team would initiate the day of procedures phase when they're ready to insert the PICC. And then also included into this power plan will be the CVC occlusion management module as well. So that'll be included. So what that'll look like is, this is what it'll look like. So this here is the multi-phase power plan here, and you'll see that there are two phases to this. So there's a pre-procedure phase, and that would include the insert PICC insertion order, and that's what will task to your MPTL, Shannon. And then on the day of the procedure, you will activate these orders, which will just include the medication orders. So it's very similar to the one you had validated before, but the alteplase now has been changed to a CVC occlusion management module. Any questions there? And if you were wondering what that looks like, it's just these orders down here. So previously it just said alteplase and then instill as directed, but this now includes the single lumen, double lumen, and triple lumen. So, so this would be all encompassed within this CVC occlusion management module.
Oh, okay.
Yeah.
And is there a expiry time for this, or does it remain active until the patient's discharged? Or
This will yeah, this will remain. Yeah.
Okay.
Yeah.
And
as
then,
long as
sorry, and then just a question, has this also been added if the patient is admitted and they have existing IVAD, or they have a different type of central line, like a tunneled central line in?
so well? Yeah, this would be specifically for the PIC. So this occlusion management is available as like an ad hoc order. So the provider could just place this occlusion management power plan as
Okay.
needed. Yeah.
Okay, great.
Okay. So any other questions or can we move along?
I think we can move along. I don't see anything else
Okay,
from there. Yeah.
sounds good. I can show you what this looks like just within CST Cerner here. So you can see here, just a second. My apologies, just gonna switch. Okay, you can see here that this is the PIC insertion power plan here, and you can see that there's the pre-procedure phase here, which has the insert PIC insertion order. So if you were to navigate now to your multi-patient task list, so that patient was CAMU 3, you can now see that there was a PIC insertion order or a PIC insertion task that has fallen onto your task list. And so just navigating back here. So on the day of the procedure, you would navigate. So this is in a planned state. And what you would do is you could just initiate the procedures. And then in terms of documentation, we would then navigate back to iView for the documentation, and similarly to previous as we've shown, you would just navigate to the central line there, and then you could add your dynamic group as well. And so we've validated the documentation piece before. Okay, so just navigating back to the PowerPoint here. So moving on to our outpatient workflow, as we left off last time, there was a decision in regards to scheduling and who would schedule the appointments in the cancer care clinic and the IB clinic at Richmond Hospital. And so the decision as it stands is that the vascular access team will not be responsible for scheduling appointments in CST to Cerner for both of these clinics, and a clerk resource from each clinic will be supporting with the scheduling of PIC insertion appointments and CVC care.
Sorry, going back, I can confirm that from an IB clinic lens that we have clerk support. I can't speak to what cancer care has done.
Yeah, it's thank you for that, Jordana. It's been validated in the cancer care clinics, but thank you. Yeah. Okay, so in future state then, what the outpatient workflow will look like is that the provider will place the ambulatory PIC insertion power plan. And so once this is placed, the vascular access team will receive the PIC insertion task on their NPTL, and simultaneously the scheduling PIC insertion order will land on the clinic request list queue. The clerk within each clinic will leave the request until they are notified from the vascular access team to schedule. The vascular access team will manage their workload via NPTL and site documentation, so the whiteboard. They'll review the patient's chart to determine if the patient qualifies. If the patient qualifies, the vascular access team will prioritize the patient, and then the vascular access team will review the clinic availability in ambulatory organizer, then call the clerk to book the patient appointment in Chatbook. So, and then the clerk will confirm the appointment with the patient, and then on the day of, the vascular access team will activate the day of procedure phase, assess the patient, and perform intervention and ECG. That will insert the ECG strip on the CVC tip confirmation form. They'll document the PIC insertion in iView and complete an insertion procedure note, and then they'll chart done on their NPTL. So one thing that will be quite new for VAT will be the reviewing of the availability in the ambulatory organizer. But we will go into this in more detail with a demo and show you what that will look like. There's a resource that has been created to be able to pull in the appointments from both clinics, specifically for the vascular access team. Shannon, are there any questions related to this outpatient workflow?
No, I don't think so. It was just the question about what the ambulatory organizer was, but you're gonna go through that. So otherwise, looks good.
Okay, sounds good. Thank you. So just very briefly, these are just some screenshots of ambulatory organizer. You'll be able to have a calendar view, and this can be viewed on a day, like on a daily basis, or it can be viewed in a week kind of snapshot. So you'll have a RHS VAT resource group, and you can see here, just in the first three here, the cancer care clinic stretchers have been pulled in, and then the stretchers from the IV clinic have been pulled in. So it was mentioned that PICC insertions would happen in these stretchers. So we've made a note to pull these in. And then just on the right-hand side here, you can see that it's pulled in both appointments so that you can have one view of what your day kind of would look like here. And then there is the week view in the calendar tab. In the week view, you'll see that it's broken down into the different stretchers. So you'll see the different stretchers in cancer care clinic and the different stretchers in the IV clinic. And then there is one that's specifically for the vascular access team. So you'll be able to see at a glance what your week might look like in the ambulatory spaces. And then there is also a day view as well. And you can see here that it's pulled in all of your scheduled appointments for the day. You can see that there's a number here. It says the number 2, and then that just means that you have 2 appointments for the day here. And then once again, you would need to set up the RHS VAT resource group. And once you've set that up, that'll be there for you every time you navigate to the ambulatory organizer. And so what I'll do is I'll just navigate to Cerner here and just show you what that looks like. So this is ambulatory organizer here. And right now, I haven't set up the resource group yet because I just wanted to show you what that would look like. So what you can do is just click on this little arrow here. And in here, you can start typing RHS, and then you'll start seeing that the different options will show up. And so you can just select this here and click apply. And then you can see for today, you have 2 appointments today for PICC insertions. You can always hover over the names for any patient demographic information. If you wanted to, you could change how you see the times. If you wanted it to be, your last appointment to your first appointment and vice versa. In here, it just displays that you have no appointments at 12 p.m. So that's kind of nice. You can see the status of the appointments. So these 2 here have been confirmed, but there could be other status as well, such as arrived, ready, check-in, no-show, etc. And then the details of what that appointment is. So for these 2, they would be coming in for a vascular access PICC insertion. And any notes here, you can always add. And then here, you can just toggle between different dates, depending on which day you'd like to view. And then the calendar view here, we would need to set that up, but I've already set it up for this one. So once again, we just set up the VAT resource group. And then for the week view, you can see here that under today's date, we have two different appointments scheduled for you. And then if you were to navigate to the different stretchers, you would see which stretcher the patient is particularly scheduled to. And then if we navigate today, you'll see that the different stretchers have been pulled in. So the 3 cancer care clinic stretchers, and once again, you can see the information. So they've been, CAMU 4 has been specifically scheduled to stretcher 1, RHS demo VAT has been scheduled to stretcher 1 in the IV clinic. But over here, you can see your full day at a glance. Any questions, Shannon?
And then we can, if the patient needs to be rescheduled or there needs to be adjustments, we can go in and edit that then, I'm assuming.
My understanding is that your role wouldn't have that, your position specifically wouldn't have that capability because you don't have reg sketch
Right.
abilities.
So we'd be letting the clerk know then if an adjustment would be made, and then the clerk would be changing it.
That's correct.
Right.
Yeah.
Okay, right. Okay, sounds good.
Just on that note, Shannon, you guys don't do anything ever on the weekend, right?
Correct. We don't work weekends or stats.
Okay, so then that should be fine that they don't have reg sketch. Okay, thank you.
And I want to add a little plug, which is something we heard in the kind of requirements gathering, is that I know that sometimes, I think you guys said that sometimes you have to move patients, but then maybe the clinics weren't updated at the time, or the clinics move something and you don't see the updates, and that leads to, so hopefully kind of taking the scheduling away from you and having that collaboration, having it all in one place will mitigate that.
Right. Yeah, that's good. Okay.
Thank you.
And Andy, just to confirm, this view will allow Shannon to see if there are patients booked for that stretcher, right? So they can use this view to also, before they call the clinic clerk as to which stretcher and at what time.
Yeah, that's correct. Yeah.
Thank you.
Does that make sense, Shannon? Like before you call, you can see that the clinic has availability, because it's going to look full of the stretcher ones are going to look full of, like, say, cancer care patients, but you can see like, oh, cancer care's got 11 a.m. at, in stretcher 1, and you see like, I see you have an availability. I'd like to pop a patient there, please.
Yeah, no, that's good to see.
That's good.
Yeah, also what their day looks like.
Perfect. Thank you, Isa and Haley, for that. We're just moving along here. I know, Shannon, that you also do CVC care. You've mentioned that it's quite rare, but we just wanted to also account for that as an appointment type as well. So just give me one moment. Just going to navigate back to the PowerPoint here. Okay. So what that'll look like from our understanding of the workflow is that if there is a need for addressing change, or a need for a VAT to support with addressing change, the clinic nurse can call VAT if they need support with the dressing change. VAT can review their schedule. So you'll be able to look at your whiteboard and the ambulatory organizer and the clinic availability. And what you can do is you can place a scheduled procedure CVC care order. So it would look like this here, this screenshot. And then in the special instructions, you could place your availability in here and say, like, you would like for the appointment to be scheduled on this day at this time. then what would happen is that the clerk would receive this request on their clinic queue, and then the clerk can schedule your CVC care appointment. Our understanding is that right now, as it stands, it's a 30-minute time slot. But should you need more time, the clerks will be able to adjust that. And then once it's been booked, then the VAT can view this on the ambulatory organizer. So you will be able to see this appointment. But Heather, I did want to confirm with you, since you're on the line, we had built the ambulatory organizer to pull in the stretchers. My understanding is that these particular procedures are scheduled to a chair. Will we be able to pull in, will we be able to actually link the order or the appointment type to the vascular access team so that they would be able to pull in these appointments that are booked?
Yeah, I'm just looking them up. So the CVC care. So these appointments are booked to a chair and a nurse resource. So yeah, if they're booked to the vascular access nurse, then they will appear in ambulatory organizer when they put that filter of vascular access nurse resource in there.
Okay, so I guess it'll show on the one that's like the consolidated view of both clinics, but it will not show up in the stretcher then, because we've only pulled in stretchers specifically for the PICC insertions.
If you're just viewing stretchers, then yes, those ones won't appear. But if you're viewing appointments linked to the VAT nurse, then it will appear.
Okay, that sounds good to me. But Shannon, does that make sense? Or I can navigate back to the ambulatory organizer just to clarify what that means. So for CVC care, so anything potentially that's dressing related, it will not, because they're actually going to be scheduled to a chair. You won't be able to see their appointments in any of these stretchers, but you will be able to see it in this view here, because it's the consolidated view that pulls anything that is scheduled to the vascular access team.
Yeah, that's okay.
Okay. And then you should also be able to see it in your day view as well, because this is not divided up into like the stretchers.
Okay. So CVC care, is that also anything related that's like in your PowerPoint, it was broken up or written as like a PICC dressing change or something. But is that also included, like if they call us to troubleshoot, or we're going to be doing some occlusion management?
Yeah, good question. We're actually going to discuss more of the occlusion management workflow a little bit later. So there is a scheduling component that is part of that power plan. However, we'd like to just discuss that workflow with you to determine whether whether you would like to use that scheduling portion in the power plan, or whether we could utilize the CVC care. So we can, yeah, maybe hopefully iron that out today.
Yeah. Okay. Sounds good.
Thank you. And then just to confirm, in regards to CVC care, this would occur within both clinics?
Yeah.
Okay. Okay. So both the cancer care clinic and the IV clinic will require the CVC care. Okay, thank you. Okay. And then next is the PICC checklist, which Isa will talk more about.
Yeah, no, Shannon and David, you've kind of had correspondence through email about this with Candy and some CC'd with myself. So we did a little further digging as to kind of where this stemmed from, and it looks like at the end of the day, it wasn't built out for VGH or any other live sites. The reason being is that any kind of checklist should really be regional across all of the vascular access teams. And at that point in time, kind of the overall consensus is that if you're assessing a patient for PICC insertion, you're already doing that assessment, and you would be documenting, for instance, the diagnosis, the reason for PICC insertion, when the patient qualifies for the PICC. And so you would put that in the actual PICC insertion note. And so there really wasn't need to do a checklist and document that in the chart prior to. So right now, my understanding is there isn't a document that's kind of part of a validated form that's part of the patient's chart at Richmond. So we don't have anything in the system for a PICC pre-insertion checklist, I guess, technically.
Okay.
If there is if there is a kind of a regional decision, or if you think that, I'm not sure if there is a regional team that discusses this, then definitely we can look at it in the future.
Yeah, we usually meet every 2 months. So there's Providence Health, VGH, Lionsgate, that's part of that. So that's something I can always bring forward to the group and see if there is a consensus or a want or need about a pre-checklist.
Sounds good.
Okay.
Mine was short and sweet. Candy, back to you.
Candy, you're muted.
Thanks. So before we move on to the occlusion management, Shannon, I can show you what the ambulatory PICC insertion workflow then would look like. Okay, so we can see here that the provider has already placed this ambulatory PICC insertion power plan. So what would have happened is that this patient then you would have received a task for this PICC insertion. So you can see here that it's fallen on your multi-patient task list. And then simultaneously at this time, the clerk would have received this on their clinic request queue. I won't go into what that looks like for the clerk because they've been shown that in their clinic sessions. So they would receive that. You would do your investigation into the reason why the patient needs it and if they qualify. And then if they qualify, on the day of, what you would do is then you would navigate to the day of procedure orders, and under the actions here, you would activate these orders. And so these orders are similar to the inpatient so after you activate that, we would do orders for signature and then sign. And so the medication orders are similar to the ones that we've already seen in the inpatient space. So very similarly, they're quite similar. Both of these power plans are quite similar. They both have the lorazepam, the lidocaine orders, and then the conditional order for the chest X-ray if if no ECG technology is available. And then we already have that scheduling piece that was previously initiated. And then once that PICC insertion is done, you would navigate to iView, and we've gone through this before. You'd go to central line, create a dynamic group, do your documentation, and then after that, you would also do a documentation. You would also complete a nursing procedure note, as that would flow to the community as well, as it gets distributed via Care Connect. And then you would also do the ECG documentation, and you would navigate to FormFast for that. And you don't want to repeat too much because we've kind of gone through this previously. And we will go into this again when we do our bootcamp training. So we'll definitely go through each step with you in greater detail as well.
I just have a question back to when it was the power plan was requested and then it was placed on our
Multi-patient task list.
yes, thank you. I think, yeah, there. When it says so pending or like the overdue, so is there just like a certain amount of time and then the system automatically puts it as overdue, or?
Yeah, so the pending is because when the provider first like places it, they do select like a request date and time. So this was requested to be done like on or today's date at this time. Even though it says overdue, it isn't accurate in terms of when it's actually scheduled for.
Oh, okay.
Yeah. So this technically, well, what we've scheduled it to is actually, I believe, today's date, but at 11 a.m. So this, the scheduled date or this date and time that you're seeing here, yeah, it doesn't reflect what's actually in ambulatory organizer. This is just when the provider had placed the order and the date and time that they had selected.
Oh, okay. So
Is,
it's essentially the time that they're putting in the request.
yeah. So what I can do is just show you.
Yeah, it's labeled a little funny because that's actually the requested date and time, which is a suggestion from the provider.
Yeah, so this is, give me one moment. So this essentially is what the provider would be placing. And so, for instance, because it would be for a future outpatient visit, this here just kind of automatically will route to like tomorrow's date. And if they don't know particularly the specific date and time, they could potentially maybe leave it. And then if they click OK, then that would, this is the date and time that would be showing.
Okay.
Yeah. So the overdue, yeah, isn't an accurate representation and isn't actually true that it's overdue. So the ambulatory organizer would be your source of truth in terms of the scheduled appointment times. Yeah.
Okay.
Thank
And
you.
then,
Yep.
sorry, there's some representation here from with the cancer care clinic with scheduling. Just a quick question, because how that's going to look from them, because they usually provide us with a chemo teaching date, like when the patient's going to be in for their initial chemo teaching, and then when their date for their first chemo is, and then we schedule the pick like in between there. So I'm just wondering, is that are they going to put that date that it's actually required, like prior to the first chemo when the physician's ordering, or is that just going to be communicated to us from the cancer care clerks?
You mean in terms of a chemo teach appointment?
Well, currently right now they'll give us the PPO, and on there they'll handwrite on there when the patient's chemo teaching date is, and then when their first treatment is, so that we can schedule the pick to be done sometime in between the teaching and their first treatment.
Gotcha.
Because we don't like to bring them in before their chemo teaching, because they usually have a lot of questions that we can't answer, and so then they're better prepared for the pick insertion after they've come for their chemo teaching, and the nurses in the teaching explain, you're going to get
Mhm.
an appointment for the
So-
PIC insertion and you're requiring that. So just wondering if that is going to be verbally communicated to us, or is that going to somehow be in the system?
It's going to be in Cerner. So basically, the patient would most likely be scheduled for a chemo teach. And if they're scheduled already for their treatment, then the treatment would actually be scheduled also. They can communicate it to you or work with you when you call them up to get your patient scheduled. They can tell you when that's happening so you can work around it. Or another way is that you can actually use one of the scheduling inquiries and actually see everything that's being done for that patient.
Okay.
Actually, can I just highlight, it's a good point. Thank you, Sam. And I don't know, Shannon, if you know Sam, he's the scheduling brain behind cancer care. So he knows all those things. The appointments option on the tab within the patient's chart is so helpful to see if the patient's already been scheduled for appointments. So you can literally see every appointment that's been scheduled for that patient in system.
Okay, so we'll have access to look at that.
You'll have access to the patient chart, so it's kind of you'll be able to either see it in the resource and the ambulatory, or there's multiple places to see. You'll find the one that works for you.
Okay.
Yeah. And also on the ambulatory organizer, when you have to, I think it's right click, there's a menu. One of the options is appointment, and it takes you right to what you just saw.
Okay. Okay, great. Thank you.
Thanks, Haley and Sam, for that. Okay. If we don't have any more questions related to that, then we will move on to the ambulatory occlusion management, seeing how we have 15 minutes left here. So Shannon, we just wanted to know what the current workflow is for occlusion management within cancer care and the IB clinics, how patients are scheduled for occlusion management, who's responsible for the scheduling, and who completes the current PPO, and when. Does that do occlusion management for IVADs, PICs, and tunneled CVCs? Does all CVC occlusion management go through that? And do patients come in for CVC occlusion management directly from home?
So current workflow. So we are usually notified by the home clinic wherever the patient is getting treatment. So whether that's at cancer care or in the IB clinic, we'll get notified, called from the nurse that's caring for the patient. So they've already assessed the line and identified there's an occlusion. But with that said, a lot of the nurses in the cancer clinic and also in the IB clinic have had the advanced education, so they actually can do their own occlusion management. So the times that we might get called is more of a consult, or if they've already tried the occlusion management and it hasn't worked, and then they're wanting to use us as a resource of what to do next. And for the PICs, it's already currently on the PPO. It's a standing order for Alteplase. So yeah, it's placed in the patient's chart when the PIC PPO is completed. And it's resides there. For IVADs, or if they have a tunneled line, they do have to get an order from the physician. They usually don't already have it as a standing order in the chart. And we do, if we get consulted, we do for IVADs and tunneled CVCs as well.
Okay.
Both clinics. And regards to scheduling, if we do get consulted, we usually just come at our most convenient time. So if there's two of us, usually one of us can break off and then come see the patient fairly quickly. Otherwise, we'll come and see the patient as soon as we physically can to help with assessment and kind of make a plan from there. So not all CVC management goes through us. Like I said, most of the nurses in the cancer care clinic and IV clinic have had that advanced education. So they usually will manage all on their own, and we get consulted if there's some issues. And they do sometimes have patients come from home to come in and get occlusion management done. So usually that's they've been seen in the community for care and maintenance. Communities contacted cancer care that the patient's line is not functioning properly. If there is a time frame, community will do the occlusion management if there's enough time, but usually if the patient's having chemo the next day or the day of, then they usually just contact the cancer care clinic, and the patient then has that management done and alteplase done. And if they're chemo the next day, they'll usually send them home and then reassess them the next day prior to chemo. They'll try and leave an overnight dwell if possible.
Okay. So it sounds like most of the nurses in these clinics then will be doing the occlusion management, and so the vascular access team is called upon if they can't troubleshoot it on their own.
Yeah.
Okay. Okay. So then in that case, there would already be like a power plan placed then for the nurses to enact on already. So they would already have all of these orders in place by the time you've come down there.
Yeah. Yeah.
Okay. And then in terms of scheduling then, as it seems that it's more kind of like on call, more urgent, do you see like a need to have a schedule, like an actual scheduling order or like an appointment type for these for occlusion management in these clinics?
No.
Okay.
Because usually they don't know that there's an issue until the patient comes in for treatment. And then the nurse, like I said, assesses the line. And then if there is an occlusion, then they work through with troubleshooting and then making a decision to alteplase and stuff. So yeah, I don't think that there needs to be something specific in scheduling for occlusion management. It would be different if we were doing it all completely like it used to be, but system didn't work. So that's why we have the nurses doing the advanced practice.
Okay. Heather, I know that we were going to discuss the occlusion management kind of scheduling piece. It sounds like vascular access team doesn't really need that scheduling piece. However, I'm unsure now if the nurses within the clinics would need this because there are orders and power plans that would be placed for them. So that might be more of a question for the nurses within the clinic. And I know you have a session tomorrow. So do you think that would be, I guess, a better place or better avenue to have that discussion?
Yeah, possibly. I just completed my session, but Gabby is hosting the ambulatory session for the IV clinic tomorrow. So we can let her know that yeah, the VAT nurses would not need to be scheduled for these. They're just pulled in on urgent cases, but it sounds like, so you think it would be relevant for the IV nurses to be scheduled? Because it also sounded like the patients are going to be assessed and the occlusion is not going to be known until the patient has arrived for their other scheduled appointment. So I guess it will be a management decision if they want to also schedule occlusion management if the patient's already scheduled for their infusion or transfusion.
I think for IV clinic, the patients that are usually coming in, they're already scheduled for their IV antibiotics or their IV therapy. So like I said, it would be found when they're in the chair for their appointment. Cancer care, though, however, may benefit from having with the nursing to book, because as I mentioned, sometimes the patients are in on their non-treatment day to get their occlusion dealt with prior to their chemo. Because otherwise, if it's just saved to chemo day, then that's postponing their chemo treatment on that day. It pushes everything back. So they certainly, in cancer care, may have patients coming in just for occlusion management a day or two before their actual scheduled chemo.
Thank you, Shannon. This is Gabriella. I do have a question for the IV clinic. Considering that I believe Alteplase has to sit there for a little bit. If the patient ever has to come back to do the follow-up or the aftercare piece of Alteplase, would that ever need to be scheduled so they can save a chair for this patient to come back and have it taken out?
Yeah, so it does need to dwell for a couple of hours. Sometimes what they'll do is they will, I guess it depends on the workflow of the clinic. They'll actually just start peripheral IV to give the patient their treatment. Why the Alteplase is doing its thing, and they'll usually just bring them back the next day. I guess there is going to be situations where that's not always possible. But yeah, if they're not going to be able to do that, then the patient does need to stay in hospital for the couple of hours while it's dwelling.
Okay, that's good to know. Thank you, Shannon. So Heather and Candy, I will bring this up at tomorrow's ambulatory session. And it sounds like there could be a potential case where if they do need to come back the day after or something, then it might be helpful to be able to schedule these patients. So I will bring that back. Thank you.
Sounds good. Thank you. And Shannon, for the cases where these patients need to be followed up on, or Alteplase has already been instilled and they're coming back the next day, are you ever scheduled to, or are you ever tasked to see these particular patients?
Rarely.
Okay.
Usually it's the nurses in the clinic that are doing the follow-up. Because as I mentioned, they're all able to do the advanced care. So part of that is the follow-up after. It would be a very rare incident. It would be like maybe in cancer care, if there happened to be casual nurses that were all working that doesn't have the advanced education, but I don't really, I'm trying to run through my head the staff that they have there. I don't think that would ever be the case.
Okay, that sounds good. Thank you. Haley, Sonia, Sam, Heather, Gabby, any other additional questions in regards to like your clinics?
I'm sorry, I've been badly multitasking and I apologize to Shannon.
No worries.
I'm so sorry. And I see that Isa has called me out for a question. So I'm sorry, Isa, do you mind just maybe if not summarizing the question right now, just even in the chat, and I'm happy to take any questions away. We are meeting with Lisa this week from Cancer Care Clinic. So we could probably clarify anything.
Exactly. Yeah. Oh, we'll just put it as an action item. It's super simple. It's pretty much, do they need a scheduling location for this CVC occlusion? Yeah, scheduling orders. Or are they just going to deal with it and put in a follow-up order for Cancer Care Clinic if the patient does need to go home and then need to come back the following day just for occlusion management?
Okay, yeah, happy to chat it. I'm hoping we have an appointment order and type that is already mapped to facilitate that. So maybe our team can catch up offline just quickly. So I know.
Yeah, I don't have a question, and if we need something, I'm pretty sure Haley will let me know.
For sure, Sam.
Sounds good. Thank you. All right. So it really sounds like that isn't, I guess, only involved when there's additional support that's needed. So really the occlusion management power plan, then Shannon, I just wanted to briefly show you. So The Alta place orders are all the same as the inpatient. There would be nothing kind of new in this instance. There was just that scheduling piece, and it doesn't sound like that needs that. However, we'll be looking into the two clinics and potentially adding the order locations for the two clinics there, but that would be more of a clinic nurse workflow as opposed to the vascular access team. Okay. And then you did mention that they will do consults to the vascular access team. So is that something for these cases where you need to consult? Is this something where you would need to keep track of if the clinic nurses are reaching out for support with this? Like, I guess, would you like it to be tracked?
It probably would be a
Okay.
good idea.
Okay.
Yeah.
Yeah, so I guess in terms of like the workflow, then if a clinic nurse does need that support, they can call that, as I believe that's what happens currently. And what they can also do is they can place the IV therapy team consult order. And then in the reason for consult, they can write like occlusion management. And so then that would fall on your MPTL. And so it'll say consult to IV3 team on your MPTL, and then you'll see the reason in the order details specifying that it's strictly for occlusion management. Any concerns with that, or does that sound okay?
Oh, that sounds good. Yeah.
Okay, sounds good. So I guess just kind of moving forward, we are at time, but I just wanted to double check with you about kind of the workflows that we've discussed today. So we've discussed the inpatient workflow in regards to the changes to the insertion power plan, which also encompasses the CVC occlusion management. In regards to that workflow, are there any concerns with that, or is that something we can deem validated? I'll just maybe go back to it just so you can quickly take a brief look at it again. So it was this multi-phase power plan that would be entered in regards to what you would be doing. This would, it's similar, this workflow is similar to what you kind of do now, with the exception of MPTL for your task management. Out-of-system communication would remain the same. And then on the day of, this is where you would initiate the day of procedures phase. And then that includes the occlusion management. Any concerns with this workflow, or can we consider this one validated?
No, you can consider it validated.
Okay, wonderful. And then in regards to our outpatient workflow, and having the clerk support with the scheduling, and then having VAT review the availability in ambulatory organizer prior to calling the clerk, prior to them booking the patient appointment and chat book. Those were kind of the main differences in the ambulatory workflow. Any concerns there, or can we also consider this one validated for VAT?
Yeah, you can validate it.
Okay, perfect, thank you. And then we also discussed the CVC workflow. So potentially dressing changes that would be required here. That would place a scheduled procedure CVC care order, and this would serve as a communication to the clerk for them to schedule the CVC care. You'll be able to see this on your ambulatory organizer, and this will be available within both clinics. Any concerns with this workflow, or can we also consider this one validated?
Yeah, you can validate that one. The only one I have thing I have a question about is if we got consulted for removing a pick, is there a
Yeah, so for any consults, so there is there is an order for removing picks as well, like if they needed the pick or the vascular access team to support with removing of the pick. And then there's also the consult to IV therapy team as well. So there are those two orders.
okay?
Yeah.
Okay.
And is that okay?
Yep.
Okay, sounds good. I guess for the specifically for ambulatory though, they could so for CVC care, then sorry, I guess was this for ambulatory specifically or for both in regards to like the removing of the
Yeah, we mostly get consulted on inpatients for
Okay.
removal.
Yeah.
But sometimes in cancer care as
Okay,
well.
sounds good. Then in the ambulatory space, and they can use the consult to IV therapy team. And then for
Okay.
reason for consult, they can place the remove pick insertion by IV therapy team. And then in the in the inpatient space, they could also use those two as well.
Okay.
So this one then we can consider validated in terms of CVC care.
Yep.
Sorry, Candy, how many more validations are there? I just have to drop off in a minute.
I think just the one more.
Okay.
Yeah. And then in terms of our occlusion management then, Shannon, your workflow will just consist of receiving that IV therapy consult order and also receiving a phone call. In terms of the management, that will be done by the nurses in the clinic because they have the training to do so, and you'll mainly support if there's additional, I guess, management that's required.
Yep.
Okay, so we'll consider that one validated as well.
Yeah.
Okay. Thank you so much. And then really for our next steps then, we'll make sure to, we'll just make sure to connect with the cancer and IV, cancer care clinic and IV clinic teams, and we'll make sure that the orders in terms of like occlusion management, we'll make sure that those are in order for the nurses in the clinic. As in regards to vascular access team, we'll just make sure that the CVC care order is part of both clinics. And then we'll just double check that chemo teaching is all good to go, that chemo teaching appointment, and just ensure we're kind of covered in that base, covered in that that the vascular pick and the pick insertion should be scheduled between the chemo teaching date and before the actual chemotherapy.
Therapy. Yeah. Great.
Okay. Thank you so much. Our meeting minutes and recording will be sent out after. And then as Isa had mentioned, the pick checklist will not be, I guess, will not be something that's in CST Cerner.
Right. Okay.
Okay.
Thank you.
Thank
Great,
you.
Thank you.
Thanks, everyone. Thanks, Candy.
Thank you. Thanks, Candy. Thanks, Shannon.
Thank
Bye.
you guys.
Thank you.